They're not going to be involved in my talk or discussion. So in this slide from my colleague Nelson Learn, you get a little picture, so you have a philosophy of how proteins can adversely affect the kidney itself. Monoclonal proteins, of course, in the form of immunoglobulin light chains combine to the TAM-horseful protein and result in tubular obstruction, the so-called myeloma cast nephropathy. However, there are two other toxic effects to the kidney that can occur. One, when the immunoglobulin deposits in a granular fashion along the basement membrane, kappa light chains almost always, in Randall type light chain deposition disease, and then when the light chain, usually lambda immunoglobulin light chain, misfolds and ends up depositing in the glomerulus and in the interstitium as light chain amyloid deposits. When we look at the last 43,000 monoclonal proteins we saw at Mayo Clinic, of course, multiple myeloma is kind of the big player in terms of the ability to damage the kidney, since nearly 20% of newly diagnosed myeloma patients will present with creatinine elevation, either due to their hyperuricemia, hypercalcemia, volume contraction, and cast nephropathy. But approximately 9% of the patients that we've seen with monoclonal proteins do have light chain amyloidosis. 60% of patients with light chain amyloidosis have renal involvement manifest as presenting nephrotic range proteinuria, the kidney being the #1 target organ for immunoglobulin light chain amyloidosis. Now, in making a diagnosis of amyloidosis, if you're suspicious of the diagnosis, you can avoid a kidney biopsy. In our experience, if a patient presents with heavy proteinuria, an immunofixation of the serum or of the urine shows an immunoglobulin light chain, or the immunoglobulin-free light chain assay shows an abnormal ratio, then a non-invasive biopsy, either of the bone marrow or of the subcutaneous fat, will demonstrate amyloid in approximately 82% of patients, and therefore obviating even the need for a kidney biopsy if you suspect the diagnosis pre-investigation. When this occurs, you don't need the kidney biopsy, and the patient will have a diagnosis within 24 hours. This is a subcutaneous fat aspirate. This is done with a needle. This is not an incisional biopsy. This needle is inserted at 9 o'clock and 3 o'clock from the umbilicus. A small little nubbin, maybe 10 to 20 milligrams of fat, are aspirated into the syringe. It's applied to a glass slide, formalin fixed, and as you can see, it's stained with Congo red. You can see the congophilic material, and you can see that the fat cell interstices are preserved. You can clearly see that this is fat. And if there's any question about this congophilic material being Congo red, I would argue that the polarized light demonstrates clear-cut apple green birefringence, and so you can diagnose renal amyloid without a renal biopsy. But diagnosing amyloid doesn't get you where you need to be. The problem is there are so many different types of amyloid, you can't be certain that the amyloid you found is necessarily due to immunoglobulin light chains. You can get heavy proteinuria from AA amyloid, you can get it from LECT2 amyloid, fibrinogen amyloid, all cause heavy proteinuria. And so finding amyloid does not end the pathologist's job. You still need to identify the type of amyloid. Now, historically, we've done this with immunohistochemistry, immunofluorescence, immunoperoxidase, and immunogold, but I would argue that this technique has been supplanted by mass spectroscopic analysis of the amyloid deposits. What I'm showing is a slide of a bone marrow, and in the upper left-hand corner, you can see the bone marrow. You can see the fat in the marrow, and you can see pinkish material in the interstices of the cells. When you put this under polarized light, you can have a technician just draw a circle around with a laser and capture right off the glass slide the amyloid deposit. And you can see in the third picture, you've removed the amyloid deposit from the bone marrow. You drop it into the tube and immediately do mass spectroscopic analysis, and I've highlighted in yellow 100% sequence identity with kappa amyloid immunoglobulin light chain. So in this situation, we've confirmed that the amyloid deposit, in this case from bone marrow, but it's easy to do on kidney biopsy, it doesn't require frozen tissue, that this is immunoglobulin light chain amyloid. When this was performed at our institution on 127 consecutive renal biopsies, it's important to note that immunoglobulin light chain amyloidosis was only present in 51% of kidney biopsies. The rest of the renal biopsies were not light chain in type. They were AA amyloidosis, fibrinogen, lectin, and a whole host of other inherited forms of amyloid that cause renal involvement and heavy proteinuria. And I would argue that nobody has a panel of antibodies that would be able to identify all these different forms of amyloid. And in this series, 30% of the renal amyloid seen was inherited. And this is relevant because I'll be talking about chemotherapy for immunoglobulin light chain amyloid, yet for non-immunoglobulin light chain amyloid, the use of chemotherapy is contraindicated. And for some of these patients, combined liver and renal transplant for these inherited forms of amyloid are the correct treatment. Unfortunately, patients with renal amyloid frequently go on to develop dialysis, and this is a continuous risk over 15 years. This is from our own case series before the use of the new novel chemotherapeutic agents. But you can see that approximately half of the patients at risk will end up on dialysis at 140 months. And so the continuous proteinuria will eventually cause irrevocable damage to the kidney, and the reason to treat the amyloid, of course, is for the prevention of end-stage renal disease, and secondly, to prevent amyloid deposition outside the kidney, particularly in the heart, where the treatment is far less effective. This also from my colleague, Dr. Lurin, shows that when we apply high-dose chemotherapy with stem cell transplantation, those patients who have renal amyloid, which is the most common indication for a stem cell transplant, and the group that responds the best, single organ renal amyloid nephrotic syndrome, that patients that respond have a much, much better survival, you can see, than those patients that don't show a clear-cut response of their light chain clone to chemotherapy. What's interesting is that healing of the glomerulus takes some time, and it's not always clear after treatment whether the patients have responded or not responded. If you look at all patients who respond and look at how their proteinuria drops, a 50% reduction in proteinuria, which is our definition of a response, takes a median of 1 year, and the maximum response takes almost 4 years, where patients who are non-responders show essentially no change, and that's the group at risk for end-stage renal disease. In addition, those patients who get a hematologic response by reduction in the plasma cells responsible for producing the amyloid light chain and show a reduction in light chain synthesis are far more likely to either preserve or improve their renal function. As you can see that if you look at the patients who get a hematologic response, almost 80% of the patients maintained stable renal function or improved their renal function. Only 30% had a further decline in their GFR, where hematologic non-responders, nearly 70% go on to develop progressive renal insufficiency. So chemotherapy here really can have a profound impact on the outcome for these patients and is therefore indicated as a trial in virtually everyone. This is just a review of 145 patients that we saw who had a renal biopsy proof of amyloid and were placed on chemotherapy trials. As you can see, about 60% of the patients had renal amyloid at diagnosis, and 35 went on to dialysis, and almost all of them eventually died, either of dialysis-related complications, voluntary withdrawal from dialysis, or the development of cardiac amyloid. In those patients who never had dialysis, there's still a significant proportion that will succumb due to the development of extrarenal amyloidosis. Patients who don't have renal amyloid at diagnosis rarely will develop renal amyloid in the course of their disease. In other words, if you present with nerve amyloid, heart amyloid, or liver amyloid, the likelihood that you will go on to develop renal amyloid subsequent is actually very, very small. And those patients barely need monitoring, since the likelihood that they'll require dialysis is only about 5%. There's some relevant things with regard to the type of light chain and amyloid that often is given short shrift. First of all, those patients who have renal amyloid tend to have a much lower frequency of cardiac involvement with amyloid. Those patients who present without renal amyloid have a much higher prevalence of amyloid. Nearly 75% will have cardiac involvement. And as you might understand, the serum albumin is substantially lower, of course, because of the nephrotic range proteinuria that is lacking in those patients that do not have renal amyloid. Patients who have renal light chain amyloid, of course, can have kappa immunoglobulin amyloid or lambda immunoglobulin amyloid, and the type of light chain makes a difference in how these patients present. If you look at a group of 137 patients with light chain amyloid, you can see that the lambda light chain type is far more likely to attack the kidney with a median urinary protein loss of over 3.5 grams. And this compares with kappa light chain amyloid, where renal involvement is much less common. Median urinary protein loss is under 1 gram. So the type of light chain becomes quite important in terms of what you can expect the clinical course and outcome for your patient will be. And as you look at the 24-hour urine median protein, patients with lambda, this chain appears to have a tropism for the kidney. These patients have a median urinary protein loss of nearly 8 grams, 7.2 grams, and those patients that have a kappa immunoglobulin light chain will run less than 3 grams. And that's a highly significant difference. So the light chain is important, and lambda light chains predict for more renal involvement and a higher urinary protein loss. Patients oftentimes are diagnosed relatively late and either are imminently on dialysis or on dialysis, and those are actually fine candidates for stem cell transplantation, because if you can induce a hematologic complete response and stop the production of the immunoglobulin light chain, it's our opinion that these patients become good candidates for renal allografting. And this is a small cohort of patients that came through our stem cell transplant program who had both renal failure and received an autologous stem cell transplant that went on to get a living-related renal transplant. And as you can see, in the 5 patients who were transplanted and received their kidneys at Mayo, 5 had successful renal engraftment, and overall 6 patients were alive with stable function, including 1 patient who declined the stem cell transplant, yet with conventional chemotherapy achieved a complete response and did well after allografting. So for patients with renal failure, the sequence of autologous stem cell transplantation followed by a renal allograft is a legitimate consideration if there is no extrarenal amyloid involvement and you've completely eliminated production of the immunoglobulin light chain with chemotherapy. Now, what about chemotherapy? Stem cell transplantation is not a safe procedure for many patients. Patients who present with a serum creatinine that's over 176 micromoles are probably not good candidates and have a very high incidence of peri-transplant, stem cell transplant, renal failure. Some patients are too old for stem cell transplant. Many of them have advanced cardiac involvement and are not candidates. So what about conventional chemotherapy? The Mayo Group has had some success with a 3-drug combination that we've acronymed CyBOR-D. The Cy is cytoxin, cyclophosphamide, and the D is dexamethasone. The B is bortezomib. Its chemotherapy trade name is Velcade. And this is a relatively well-tolerated regimen, and when we reported our first 17 patients with a significant proportion of cardiac involvement, responses were seen in 94%, and 71% of the responses were complete, and by that I mean complete abrogation of light chain production. Time to response is very fast, and patients that were deemed too high a risk for a stem cell transplant subsequently became eligible for a stem cell transplant. So for renal amyloid light chain patients that are candidates for chemo, we would recommend first a stem cell transplant. If they're not candidates, we think this is a reasonable chemotherapy regimen for referral to your oncology colleagues. Of course, all amyloid is not light chain amyloid, particularly in less developed areas of the world. Secondary amyloidosis, or AA amyloidosis, is a common problem. And here's some results regarding 44 AA patients and matched controls that were transplanted, kidney transplant. And you can see that the graft survival at 1, 5, and 10 years runs between 88, 78, and 62% respectively. That the controlled graft survival rates were not significantly different. So these patients did as well as patients who had native renal disease responsible and did not have systemic amyloid. Although rejection seemed to be more common in controls, likely related to immune suppression, immune deficiency in patients with secondary amyloid, and a non-functioning graft and death with a functioning graft was more common with secondary amyloid, although this did not reach statistical significance. You'll find these slides on our website at msmart.org, where we recommend how we would treat patients with immunoglobulin light chain amyloid. And we make two distinctions. The first, eligible for transplant. The second, not eligible for transplant. For those eligible for transplant, we proceed directly with stem cell transplant, and most patients do not require any form of induction chemotherapy. Those that have a greater than 90% reduction in their free light chains, we believe should be considered responders and require no further therapy. But for those patients who do not achieve a complete response, depending on whether they have high risk, by that I mean severe cardiac involvement, those patients will go on to bortezomib-based therapy, such as the Cy/Bor-D regimen that I showed 2 slides earlier. For those patients who are transplant ineligible, we'll often give them a trial of melphalan and dexamethasone, which is a regimen that's available worldwide and doesn't involve the expense of bortezomib, which runs approximately $13,000 per month for treatment, is often not reimbursed. And those patients that do show a significant response, we will observe. Those patients that don't have a significant response, we will move on to second-line therapy that will be bortezomib-based. And again, you can find this at msmart.org. So I think I'll stop with that and leave a few minutes for questions if I may.
Thanks.